and functioning. Screening tools for eating disorders can help identify individuals who may need further assessment and referral to specialized services. Eating disorders can be prevented, detected, and treated with evidence-based intervention and multidisciplinary care. Those are my references, and thank you very much. I hope you enjoyed it.
Thank you, Dr. Rasha, for such an interesting topic. Okay, so up next, we have two article summaries will be presented by two of our amazing residents. The first topic or the first article is concerned the topic that I think most of you has faced. I want to ask a question. How many of you ever faced a pregnant lady asking about a common over-the-counter medication, if it was safe or not in the clinic? Raise your hand. Whoever faced a friend or a colleague outside the clinic asking about the same question, like in real life. Okay, so it's a really common topic. So let's welcome Dr. Karam Mohammed Basham. He will be presenting over-the-counter medications in pregnancy. Let's give a big clap to Dr. Karam.
Good morning, everyone. First of all, it's my pleasure to present an article summary at the conference. My name is Karam Basham, and I am a family medicine resident at King Saud Medical City. I'm going to talk about over-the-counter medication in pregnancy. This article was published recently in AAFB, October 2023, and I'm going to summarize it to you in the next few slides. So starting by definition, as we know, over-the-counter medication is medication that we can buy from a pharmacy without any prescription. Unfortunately, there is a few randomized controlled trial of over-the-counter medication in pregnancy exist. As a physician, we should encourage non-pharmacological intervention for self-limited to mild diseases and to select the safest medication for moderate to severe conditions. During the 2nd to 8th week after conception, it's a critical time to limit medication exposure to prevent birth defect due to the organogenesis, which is the formation of the baby's major organ. Also, in the 3rd trimester, it is essential to abstain from medication that could have adverse effect on both late pregnancy and newborn period. This is my outline. I'm going to talk about this the next few slides, starting by nausea and vomiting, which is one of the most common presentation of pregnant women at primary health care. We can advise them as non-pharmacological to start prenatal vitamin 1 month before conception. Also to making dietary modification like eating small, frequent meals and dry bland foods. Studies found that ginger is acceptable to use in the 1st trimester. However, there is increased risk of vaginal bleeding with the use after 17th week of gestation. Moving to pharmacological, we have vitamin B6, pyridoxine, with a dosage less than 100 milligram. It's safe as initial treatment for nausea and vomiting during pregnancy. Also, 1st generation antihistamine are acceptable to use with no risk of adverse outcome. GERD during pregnancy, studies reported that 40% of a pregnant woman experience GERD during pregnancy. We can advise them to elevate their head of bed while they are lying down or sleep, reduce or avoid trigger foods such as fatty, spicy, or citrus food. Also to avoid lying down within 3 hours after eating. For pharmacological, calcium carbonate is a preferred antacid for GERD during pregnancy. 2nd generation antihistamine is acceptable to use. Also, proton pump inhibitor are acceptable to use between the 2nd and 3rd trimester. And there is possible risk of minor malformation. Functional constipation, which is one of the most common presentation also. We can advise pregnant women to increase water and fiber intake to promote them to engage in light physical activity. Also to women who complaining of constipation during pregnancy, we can advise them to take iron every other days. For pharmacological treatment, we have bulk forming agent and also osmotic laxatives such as Movicol, magnesium hydroxide, but prolonged use of osmotic laxative will lead to electrolyte imbalance. As we know, chronic constipation will lead to hemorrhoids. We can prevent hemorrhoids non-pharmacological, such as constipation. Additionally, we can advise them to take a sitz bath to prevent hemorrhoids. If it's ineffective, we can give low-dose hydrocortisone. Topical lidocaine and topical bromoxine could be considered. Medication for skin disorder. As you can see, we have acne agent. We can give them azelaic acid or benzyl peroxide. It's safe during any trimester with no adverse effect. Give clotrimazole or ramiconazole. It's more effective than nystatin. For atopic dermatitis, the first line treatment, it's a low dose of hydrocortisone. Studies found that adapiline or Differin, it's contraindicated during about 18 to 30% of pregnant women experience rhinitis symptoms, and it increased during pregnancy. First and second generation antihistamine are acceptable to use. Hypertonic saline nasal rinse safe also to use. 50 microgram in each nostril once or PID is the preferred agent and most widely studied in pregnancy. Headache during pregnancy occurred in 40% of pregnant women. First line over-the-counter treatment for headache is acetaminophen with or without caffeine, with the total daily caffeine intake not exceed 200 milligram from beverage, medication, or foods. For prophylaxis for migraine, we can give magnesium oxide at dose of 400 to 800 daily. NSAID can be an option in the second trimester because the studies found that when pregnant women use NSAID in first trimester, it is associated with the premature closure of ductus arteriosus. For low back pain, we can advise pregnant women to do stretching, to engage in light physical therapy, also to use a heating bath, but not in the abdomen or the pelvis. Moving to pharmacological, we have acetaminophen as the first line therapy with dosage not exceed 4,000 milligram. Lidocaine patches can be considered also for low back pain. The American College of Obstetricians and Gynecologists at the United States Preventive Service Task Force recommend low-dose aspirin for women who are at increased risk of preeclampsia. As you see in the algorithm, if a pregnant woman or a patient present to prenatal care, and she is between 12 and 18-week gestation, and she had one or more of high-risk factors such as autoimmune disease, gestational history of preeclampsia, or gestational diabetes, we can initiate aspirin 81 milligram daily between 12 and 18th week, and also continue until delivery. If she doesn't have any of high risk, and she had two or more of moderate risk factors, such as family history, obese pregnant woman, age 35 or older, also we can initiate aspirin. Fever during pregnancy, especially in the first trimester, is associated with cleft lip, palate, and neurodevelopmental disorders such as ADHD. Acetaminophen is the preferred treatment due to the risk associated with NSAID, as we said before. For insomnia, we can encourage pregnant women to improve sleep hygiene through exercise, limiting caffeine intake, also restricting fluid intake in the hours before sleep. For pharmacological, we have first generation antihistamine are safe as needed for pregnant women. Melatonin is contraindicated during pregnancy because studies found that there is cross of placenta. Melatonin can cross placenta. Lastly, we have a herbal supplement. Approximately 29% of women worldwide reported taking herbal supplement during pregnancy, and many studies that did not support the using of herbal supplement during pregnancy, even if they are effective, because of its safety and adverse reaction. To summarize, this is my key recommendation for practice. As we said, we can initiate aspirin 81 milligram between 12 and 18 weeks of gestation in women who are at increased risk of preeclampsia. use of NSAID should be by caution because it's there is association with the increased risk of a premature closure of ductus arteriosus. Acetaminophen should be used at the lowest effective dose. Ginger are acceptable to use, but there is a minimal risk of vaginal bleeding. Lastly, first and second generation antihistamine are safe to use throughout pregnancy. This is the article. You can scan it and download it. Thank you for your attention.
Thank you, Dr. Karam. It is really refreshing to see such a competencies in our programs. Coming next is a topic that has a major outbreak during the 2022-2023. We'll be talking about the monkeypox. We'll have a rapid evidence review, and it will be presented by Dr. Sara Saeed Al-Awami. Let's give a big welcome to Dr. Sara.
Assalamu alaikum. My name is Sara Al-Awami. I'm a family resident. Today, I'll talk about MPOX Rapid Evidence Review. On this article, we'll discuss about epidemiology, prevention, vaccination, diagnosis, and treatment. So, MPOX, formerly known as monkeypox, which first isolated in monkeys in 1958 and first human case was in 1970. In addition to monkeys, apes, dogs, and rodent, all can be infected with MPOX. So starting from 2022, increasing number of total cases reported outside Africa and continent were present. As of June 2023, total case number in the United States and globally. And there's some cases of death. Transmission is primarily through skin contact lesion. So avoiding skin contact with anyone suspected to have MPOX is the first step. Also, the virus can be detected on samples taken from blood, anus, throat, urine, and semen. There is also a risk of respiratory spread. So PPE should include gowns, gloves, eye protection, and N95 respirator when taking care of patients you suspect to have MPOX. We have two vaccines currently approved by FDA in US. First one is Jynneos, which is live attenuated vaccines, which is safe for immunocompromised patient. It's 2 doses, 4 weeks apart. The second one is ACAM 2000, which is single-dose live vaccinia virus vaccines. It should be only given to immunocompetent, non-pregnant people. And we have to avoid it in patients with skin conditions like atopic dermatitis. FDA box warning for possible myocarditis, pericarditis, and encephalitis. We can give it either vaccines as post-exposure prophylaxis and pre-exposure prophylaxis, ideally within 4 days after exposure, but we can give it up to 14 days after exposure. And here on this table, we can see the high risk people for exposure. So we have to give it, we have to give them the vaccines. We should suspect the MPOX to patient with typical rash, often pustular in anogenital area, face, trunk, and extremities, which is the typical course of rash. Is macules, what takes 1 to 2 days, papules, it takes 1 to 2 days, vesicles also takes 1 to 2 days, pustules 5 to 7 days, scabs, it takes 7 to 14 days. The patient is no longer contiguous after all scabs have fallen off and underlying skin is intact. And this is a typical rash taken from CDC website. We can see the picture. Okay. Symptoms, most of the patients are asymptomatic during an incubation period, which may last from 5 to 21 days. But if the prodromal period is present, patient will complain of fever, myalgia, fatigue, malaise, and lymphadenopathy. Here's the differential diagnosis: herpes simplex virus, gonorrhea, syphilis, Paget syndrome, recurrent after stomatitis, and Varicella zoster virus. PCR can be obtained for diagnosis, or swabs of the lesion. It should be taken from two specimens from different lesions. Treatment: the mainstay of treatment is suppurative care, but we can manage the patient for pain management, fluid maintenance, hemodynamic support, auto-inoculation covering the eyes, mouth, and nose. Okay, we have antiviral medication can used for smallpox, can be used for mpox, which is tecovirimat, it's FDA approval, and the other one is Cidofovir or Bencocidofovir. The other one is CNJ-016, which is vaccine immunoglobulin to treating the complication. Okay, when we refer or hospitalize the patient, it depends on location and severity, comorbidities, risk of spread. And the goal of the treatment is to pain control, soft tissue, superinfection, and pharyngitis. Finally, prognosis is good for most of the patient, but the high-risk patient have poor outcome. Possible complications include bacterial superinfection of skin lesion, dehydration secondary to oral lesions, possible encephalitis, keratitis, and respiratory distress, and some of the death. These are my references. Thank you.
Thank you, Dr. Sara. Please, let's give a big supportive clap for our residents. So up next, we will have our question session for the questions you've sent through the barcode. We will start with our first question for Dr. Muna. Can we use methyl dopa safely as an antihypertensive therapy during pregnancy? Dr. Muna.
Yes, methyl dopa is safe during pregnancy to treat gestation hypertension. However, usually we don't like it that much anymore because it causes depression.
Okay, good. Another question also for Dr. Muna. Safety profile for GLP-1 and SGLT2 in pregnant women.
It's not yet studied enough to say that's safe during pregnancies.
One more question. Is there a specific TSH target for each pregnancy, or is it the same as the preconception, and how often we should repeat testing?
Yes, during pregnancy, we need to increase the levothyroxine doses from 7 to 9 doses per week. There is target by trimester, but I cannot recall them now. And we need to repeat TSH in each trimester if it's controlled. If it's uncontrolled, after we adjust the dose, we need to repeat it after 6 weeks.
Thank you so much. For Dr. Saba, we have 3 questions. The first one is if there is any medication or instructions to tell the patient with the end-stage renal disease with dialysis before dialysis time to prevent sick of the patient, like hypotension after dialysis?
Usually these are taken care by the nephrologist, and usually after they do the dialysis, they give them medication to increase their blood pressure because of hypovolemia. So patient who is pre-dialysis, they don't need to take any medication usually after.
Okay, thank you. The second question is family physician eligible to prescribe Finerenone for diabetic patients with chronic kidney disease?
No, it's only for the specialist.
Okay. Last question is, can we use antiviral medication, Cyclovir, for treatment of herpes zoster disease in patients with chronic kidney disease?
Yes, and the dose adjustment only if creatinine clearance is around 10. And as I mentioned, there is a lot of medication. We cannot cover all. So always check the creatinine clearance or GFR in the leaflet that include or online to check for exact dose. Thank you.
Thank you so much, Dr. Sabah. Thank you. Okay, so we'll be having a short break and then come back later to resume our interesting topics. We'll be showing a barcode to showcase your amazing skills in photography. So please take as much pictures as you can, and if you want, you can share it with us. We'll be displaying the barcode shortly. Thank you so much.